Pod.
Hello and welcome back to BNSSG Peds Pod. I'm Ruth Bowen. I'm a Bristol GP working for the BNSSG Training Hub, bringing baby, child and young person education to primary care clinicians. I'm delighted to be joined today by Pippa Bowen, who is a general paediatrician at Bristol Royal Hospital for Children with an interest in endocrinology.
Hi, thank you for inviting me.
Thanks so much for coming to speak to us about puberty. So I've got lots of questions for you and we'll base it around 3 cases just to ground our knowledge a little bit. But before we start that, would you mind just talking us through what the normal stages of puberty are and how we can objectively record the stage that our patient's at?
Yes, of course. Puberty, as you all know, is the sequence of physiological events that occur with development of secondary sexual characteristics, a pubertal growth spurt, and then you eventually get adult stature and you also get reproductive capability. This usually on average in boys occurs at 11.5 years and girls 11 years. It is governed by the hypothalamic pituitary gonadal axis, and so we have to understand that a little bit to make sure that we can understand what's normal, what goes wrong, and assess and investigate when they present to us in our clinical practice.
Thank you very much. So if we go first of all to case number 1, parents present to primary care with 14-and-a-half-year-old Joshua with concerns that he's shorter than his peers. On examination, there's no pubic or axillary hair and 3 male testes bilaterally. He's otherwise fit and well, with no history or examination findings of systemic illness. On further questioning, Dad mentions that he was a late developer. First of all, what is the cut-off for puberty to be considered delayed?
Delayed puberty is different in girls and boys, and it's usually 2 standard deviations away from the mean in the population. So it's different in different countries and in different ethnic groups. But in the UK, we have a cut-off for no breast bud development in girls by 13 years and no testicular development or signs of puberty in boys more than 14 years. We often see boys presenting as short for their age rather than delayed testicular development. And in girls, you might often see delayed menarche, which is anything around 15 years and above.
And how common is delayed puberty?
Delayed puberty in itself can be quite common. The literature says about 2.5%. The commonest thing we see is boys with constitutional delay in growth and puberty, but it's really important to rule out the other pathological causes both in boys and girls. With delayed puberty, usually boys is constitutional and less likely to be pathological, whereas girls, there often is something to find on investigations. It's different in early puberty, the other way round. Often girls will go into early puberty and it will be idiopathic with no underlying problems, but with boys, there's often a pathological cause that you have to find.
Thank you, and I'm sure we'll talk about that in a little bit more detail. Joshua has 3 male testes and no signs of pubic or axillary hair. Can you talk us through what Tanner stage that would make him and what is Tanner staging?
Yeah, of course. So again, as we mentioned in the beginning, the hypothalamic pituitary gonadal axis, and that's what starts to trigger puberty. So you get the gonadotrophin releasing hormone from the hypothalamus in a pulsatile fashion triggers the anterior pituitary to release LH and FSH. And then they act on the gonads to release testosterone and estrogen. There is a caveat that actually pubic hair and axillary hair development is by adrenal androgens. So although we've got that hypothalamic pituitary gonadal axis causing the testicular development, the breast bud development, the growth and the change in the genitalia, you've got more of the adrenal androgens causing axillary pubic hair, acne, body odour, all those kind of things. In girls, what tends to happen is you first of all get breast bud development. So after the trigger of that HBG axis, you'll get breast bud development. You'll get further breast development from then on. You then get the peak height velocity quite soon into pubertal progression in girls. Then you'll get the progression of pubic and axillary hair development. And then you get menarche, the start of your periods, right at the end of puberty. It's important to tell parents sometimes that from breast bud development to menarche can often be 2.5, 3 years. So they come really worrying that there's breast bud development and they're going to start their period soon, but there actually is that delay as you go through puberty. Whereas in boys, you get a different pattern. So you get testicular development, size testes, so usually 3 mils and under prepubertal. Once they get 4 mils and above, they're starting their pubertal development. You'll get penile growth with that, then you get the pubic and axillary hair development, and then you get more growth of testes, penis, scrotal changes, and then you get the peak height velocity right at the end with boys, so it comes a lot later. And you tend to have their voice breaking at about 8 to 12 mils size testes. When we follow progression, we can then assess it clinically and see where they've got through their stages of puberty. Often children and parents, quite an anxiety-driven thing, having their pubertal status examined. So it's really important that we create a safe environment for that. We explain what we're doing. We offer a chaperone. And you explain both to parent and child exactly why you're doing it and what you're going to do at each step. We need to examine because we know that self-reported pubertal changes have really poor inter-rater reliability. You'll find out in a bit as we talk about different causes that you really need to know what size those testes are. You really need to see whether there's breast development or not. The measure we use is something called Tanner stages, as you alluded to earlier. And they can be found on the internet. I do look at them all the time in clinic, so I'd recommend doing that. Initially, Tanner stages were breast development, pubic hair, genital changes in boys, but we've added axillary hair as well. So you get them ranging from 1 to 5. 1 is pre-pubertal across all, and 5 is adult post-pubertal changes across all. In breast development in girls, you'll have completely flat chest with no breast development, just a raised nipple as B1. And then the first sign will be breast buds as B2. Often you think there's breast development, particularly when you've got some obesity there. So it's really important that you lie the child flat. You palpate for breast buds, which are much firmer underneath, rather than just adipose tissue, which would be very generalised. Then you'll get B3 and you get changes around the areola, but it's not separated from the breast. And then B4 you get the raised areola as well as the raised nipple. 5 is adult breast. Pubic hair, again, 1 is nothing at all. 2 is a little bit of dark hair on the mons pubis usually, but no spread outwards. And then it develops 3 and 4. Usually the spread from the mons pubis, adult type becoming curly, thick, long, and then onto the thighs as well, both for boys and girls. With genitals for boys, we need to use an orchidometer. We have them all in clinic. I'm not sure in primary care, do you have access to orchidometers?
We don't know. So the nearest I've managed to get is actually you can get some printouts on A4 paper which show you the approximate size. So that's about as good as I've managed.
I thought that might be the case, and that's tricky because testicular size is really important. The orchidometers, for those that haven't seen them, look like a beaded necklace with larger size beads, but generally anything above 4 mils is that you're starting to show signs of puberty, and then up to 20 to 25 mils is adult type. Tanner stages uses that, but they also use penile development and scrotal changes. So they're all 1 to 5. Axillary hair, the newly added one, is 1 to 3. So none, some sparse downy type hair, and then adult type hair. Another part that's really important is growth. You want height, weight, BMI, and also, if possible, if you've got previous heights, growth velocity. To be reliable, it has to be 4 months apart or more. And then other important parts of the examination for pubertal problems in children are general health, malnutrition, particularly with delayed puberty, evidence of an eating disorder, excessive exercise, other signs of chronic illness, or psychological stress that's been prolonged, so neglect or abuse. We also like to examine the abdomen for masses, pelvic or abdominal masses, the testicles for testicular masses, and we like to look at the skin, particularly for more early puberty, but things like café au lait patches or signs of neurofibromatosis, they all hint to what might be the underlying causes. And then finally, what's really important is a neurological examination. You'll find out a bit later, causes of early and delayed puberty can be brain tumours. So it's important to make sure there's no symptoms or signs of that.
What different causes of delayed puberty are there?
I like to think of it in 3 different ways. You've got what we talked about initially, which is constitutional delay in growth and puberty. So this is where there's a delay, but there is no pathological cause. It usually runs in families, so it's important to ask the family history, usually the male family history. That will be delay. They're otherwise completely healthy on your history examination. They'll have low baseline gonadotrophins. And they'll either start to go through puberty on their own, so you'll start to find early signs of puberty and you may want to take a watch and wait approach. Or there is evidence that if they haven't started puberty and they're quite late, you might want to give them pubertal induction with a 6-month or a year's course of monthly testosterone injection. And then you'd see them after that to check whether there has been progression. That works in a lot of cases and is really good for the psychological stress that boys often feel of being shorter and also with their sporting ability as well.
And I've always believed that the constitutional causes make up about half the cases. Does that sound about right from your experience?
Yes, I think it's the commonest thing we see. It's really tricky from history examination and in initial investigations to pick it out from another cause of hypogonadotrophic hypogonadism. We call it hypog, which just means that you've got a central cause for the delayed puberty. So you've got low LH, FSH, and therefore your gonads are not working. You've got low testosterone and low estrogen. Part of that can be functional, but different from constitutional. It's from underlying causes like a chronic illness. So celiac, thyroid, inflammatory bowel disease, cystic fibrosis, all these kind of things. You can also get it from eating disorders, malnutrition, excessive exercise, so you can see it in gymnasts. So it's important to ask about that. You can see it in people who, as I've mentioned before, have been under a lot of prolonged psychological stress. So asking about that as well. There are pathological causes, central causes of these pituitary problems. Often it can be notable in the history, things like previous traumatic head injury, cranial irradiation, but it can also be from tumours. So it's important to ask about the neurological features, to ask about symptoms or signs of pituitary hormone deficiency. So fatigue, hypothyroidism, growth arrest is really important in that one. So if they started puberty, started growing and then it arrested, that's a real red flag and we would want to see them pretty quickly. And as I was saying, the hypog, how you differentiate that often between constitutional is you'll give them both some pubertal induction with testosterone. And then the hypog will not have any development. And that's when our tertiary endocrinology colleagues come in and do all their specialist things. That's 2 of the groups I look at, the constitutional and the hypog. You can also get gonadal failure, so hypergonadotrophic hypogonadism. Your gonads aren't working for some reason, so you've got limited estrogen and testosterone production. Because that's low, there's a negative feedback, and then you get raised baseline LH and FSH. There causes anything that can cause gonadal failure, either genetic, congenital, or anything that's damaged the testes, so previous testicular torsion, operations on the testes, mumps will be one of the infections that you'll be familiar with. Also, any treatment for malignancy. In girls, probably the commonest one is genetic, so Turner's syndrome, XO. For any short girl or girl who's delayed or had pubertal arrest, it's important to do a karyotype to check for Turner's.
That breaks it really nicely down into the constitutional, the central and the peripheral causes, which is a really nice, logical way of thinking about it. So how would you approach Joshua?
With Joshua, we would take a history. We've covered quite a few of these things, but you'd be wanting to know about his general health, any symptoms of chronic disease, any underlying other causes such as the eating disorders, exercise, weight loss. You would also want to particularly know for boys their sense of smell, because there is a congenital condition called Kalman syndrome where you get delayed puberty, hypogonadotrophism, and you get the absence of smell. Neurological features, family history is really important. And then you would want to examine, again, to look for any signs of illness. Particularly you want to do a neurological examination. You would want to do the Tanner stages and growth. In primary care, it might be helpful if you could do baseline blood tests, looking for chronic illness, full blood count, kidney function, liver function, thyroid function, and celiac disease. They're all really important. And if you could do baseline LH and FSH, that's helpful, as we've discussed before, for us to put into what category of causes of delayed puberty it is and which path we're going to go down. Any who doesn't have any signs of development by 14 in boys and 13 in girls, we would want to see in clinic.
So you would want us to do the blood tests. Would you want us to do an X-ray of the left hand and wrist as well, or would you prefer that we leave that to you?
I think we can do that in clinic. Just by doing those baseline blood tests, it really helps that you might identify any conditions that might need treating. Bone age is really helpful because it shows us how long they've got left to go through puberty, whether they are delayed. So in constitutional delay in growth in puberty, you would have quite a significant delay in bone age. And that's really helpful to say to parents, look, I know they're 14, but they've got this room in their bones to grow. We just need to wait, or we need to give it a nudge to carry it on. But we can do all of those in secondary care.
Okay. So any boys without testicular development by 14, any girls without thelachy by 13, you want to see them. If there's arrested puberty, you want to see them a bit faster.
Yes, and any neurological signs or symptoms, we would want to see them sooner as well.
And that's even if we think there's a constitutional cause, so you wouldn't want us to address that first. You would say, actually, we can't rule out the central causes and therefore, regardless, send them to you.
Yes, so I would do both. So address the causes you may have found already, but then also send them for us, because likelihood is that they'll need urgent MRI of their head.
Perfect, thank you. Coming on to our second case, thinking about precocious puberty, Dad presents with 7-year-old Amir because he's noticed over the last 6 months that his testes look larger, the texture of his scrotum has changed, and he's started developing the odd pubic hair around the base of his penis. There's no penile enlargement noted, and he has no axillary or facial hair. On examination, Amir is Tanner stage 2 for his testes. His testes are of normal shape, size and colour, with both testes easily palpable and no masses to note. Height and weight are continuing to consistently track between the 50th and 75th centile. What are your initial thoughts with this case?
This case, to me, immediately has some red flags because it is a boy who has gone into early puberty. We often see idiopathic precocious puberty in girls, but boys, there's often an underlying cause that is quite significant and needs urgent treatment. So the fact that he's 7, early puberty with boys would be any signs of pubertal development before the age of 9. Being 7 is quite significantly below that. And you've also got signs with testicular enlargement that it's central. It's coming from gonadotrophic dependent puberty. When we look at early puberty, for E, split it into 3. So we see gonadotrophin dependent precocious puberty. This is where you get early activation of that HPG axis we were talking about earlier. We can get gonadotrophin independent precocious puberty. So this is where you get excess steroid hormones or androgens, so estrogen or androgens, and they can be from different places. So things like the gonads, so an ovarian or testicular tumour, the adrenal gland, an adrenal tumour, or disorders of the steroidogenesis pathway, particularly things like CAH, congenital adrenal hyperplasia. Or it can be exogenous sources, so it's always important to ask about what they've been exposed to. And then thirdly, I put them into one group, which is pubertal variants. So this is where you've got an isolated early sign of puberty, but without an underlying disorder. You can get something called premature adrenarche, which is where you get signs of pubic and axillary hair development, body odour, a bit of acne, but no breast or testicular development. You can get premature thelarche, which is early breast development, usually in the preschool age, and then you can get isolated menarche, which obviously needs investigation in a different way. So that's how I look at my causes of early puberty.
Thank you. And are there any key elements of the history or examination that you would want a primary care clinician to do for Joshua? So worrying about precocious puberty.
With early puberty, it's really important to get into your head from history and examination what actually is the problem. Is there activation of that central axis? Is there breast bud development or testicular development? If there is, then you'd be going down that path. If there isn't that, and you've just got the axillary hair, the pubic hair, the body odour, then you would be looking at other causes. That really helps. So you want to know that from history and from examination. You want to know neurological symptoms or visual disturbances. Past medical history that might lead to early puberty, so where there's been neurological insult, cerebral palsy, hydrocephalus, previous brain tumours, cranial irradiation, also any family history. And that's history itself. And then on examination, very similar. You'd want Tanner stages, growth parameters, general health examination, neurological examination, fundoscopy if you can, or asking them to go to the opticians and get fundoscopy and visual fields. And you'd like to feel for the abdominal and pelvic masses, thinking of those tumours, and testicular masses. Particularly in girls, it's important to look for any clitoromegaly. That might point to a sign of virilization and an adrenal disorder such as CAH. And then skin assessment's really important, looking for café au lait patches, because that can indicate a rare condition called McCune-Albright syndrome or signs of neurofibromatosis type 1.
So how would you want a primary care clinician to manage Joshua? What would you want them to do next?
Any early puberty in boys or girls should be referred to secondary care.
What would be your cut-off?
In boys below 9 and girls below 8. More urgently would be any boys. More urgently would be any girls lower than 6, particularly the newborns and infants, because there's more likely to be a worrying cause underneath. And obviously those with any feature of an oncological or a neurological process.
Apart from referring, is there anything else that you would want us to do in the interim? Would you want us to do any blood tests in this case?
You can do. Again, baseline blood tests are helpful. LH and FSH is helpful. Not as helpful as delayed puberty, because it happens in a pulsatile fashion early on in puberty. So your LH and FSH secretion often can be raised at night, and they're pulsatile, so they're not very frequent, and you might just catch them at a low period, but they still are in early puberty. For it to be pulsatile all the time through the day, the 24-hour period, they're often late into puberty, and you would see that clinically. So it is helpful to have, but it doesn't give us the answer one way or the other. Estradiol for girls is helpful, and testosterone for boys. We then in clinic would think about doing extra investigations such as an LH-RH stimulation test. So this is where we stimulate the LH and FSH and check whether they actually are in puberty. And we would also do a pelvic ultrasound in girls, because that helps to see whether there's been uterine development and ovarian development. We wouldn't be expecting you to do those in primary care.
When parents ask what to expect for the next stages, it's good to have an idea of that. Thank you. Coming on to our third case to talk about premature adrenarche, which you've touched on a little bit already. Mum presents with 6.5-year-old Kira, concerned about the appearance of hair in the armpits and groin, as well as increased hair on the legs. There's no history of menses or breast development, but Mum has noticed body odour on a few occasions over the last 3 months. Kira is otherwise fit and well. Her height is on the 91st centile, increased from the 75th, and weight has remained between 91st and 98th centiles. Pippa, what do you think is going on in this case?
This is something we commonly see, and I think you will commonly see in primary care, which is pubic and axillary hair development, bit of body odour, acne. In usually girls, can be boys, but usually girls between 6 and 8. And it's quite easy to say, oh yes, we've seen many of these, this is premature adrenarche. But it's really important to make sure this isn't a problem with the adrenals themselves. So an adrenal tumour or a disorder of the steroidogenesis pathway, particularly something like late onset congenital adrenal hyperplasia. We would still like to see these in secondary care. When we would examine, we often check that there is actually pubic hair, because quite a lot of the time we come with that reported and it's just a bit of normal downy hair on the mons pubis. The girl might be slightly overweight and has got a bit of body odour. She might look like she's got breast development because there's a bit of adipose tissue there, but when you palpate there's no breast buds. So those ones we can really reassure and just say, no, not in early puberty and we don't need to do any investigations. But with these girls, we're thinking it's premature adrenarche. We've got no signs of a central pubertal start, such as the breast development, and it's all isolated pubic and axillary hair. We need to check whether there's any signs of problems with the adrenals. So we often at this time would do the blood tests, as we've talked about before. We'd add something called 17-OHP, one of the enzymes that's commonly raised in CAH. We would also collect a urine for something called a urinary steroid profile. Now that's a non-timed collection, random urine, that goes off to a special laboratory in London, and they're able to look at the excretion of all the steroids and tell us whether it's a normal pattern or whether there's likely a problem that needs further investigating with DAHS and androstenedione and all these kind of things in conjunction with tertiary endocrinology colleagues. If it was abnormal, you would get an ultrasound scan of the abdomen and look at the adrenals themselves. But if you've got a girl who's got static pubic hair, axillary hair, body odour, bit taller than her peers, maybe a bit overweight, slightly advanced bone age but not more than 2 years, and a normal urinary steroid profile and 17-OHP, you can say this is premature adrenarche. And I tend to explain to parents as your adrenal glands are just getting into practice before they start. It does not mean that you will go into early puberty.
Would you be wanting us to do anything in primary care? In terms of the investigations, they all sound quite specialist.
Yes, I don't think so. I think what's really important is that examination and that history, because that really helps us with our triage of who needs to be seen by whom and how quickly. So knowing those features rather than relying on a parent or a child's self-report of those is really helpful.
And how common is premature adrenarche?
So I think it's really common because I see it all the time, but I'm not sure exactly how common it is.
And you mentioned being a bit taller, potentially being a bit overweight. Are there any risk factors that we should be aware of that predispose to premature adrenarche?
You might go into more early puberty if you're from certain ethnic groups, girls mainly, but you can see it in boys.
Brilliant, thank you. What would be the really concerning red flags of delayed or precocious puberty? Is that those things that you've gone over already with neurological causes? Yes,
so any early puberty in boys, any arrested puberty, any neurological signs or symptoms or concerns about an oncological process, and any other signs of pituitary hormone deficiency. So signs of hypothyroidism, arrested growth, fatigue, cortisol deficiency, those we would like to see sooner.
Brilliant, thank you. Do you have any key take-home messages or calls to action that you'd want primary care clinicians to incorporate into their practice?
From my experience, the main thing is that girls, but particularly boys, come to clinic very, very anxious when it's about their puberty. So I think the important thing for me is really creating that safe environment for that young person, explaining in ways they can understand what puberty actually is, what you're going to do, really why you need to do it and why it's important. That they are allowed to say no, respecting that decision and really getting parents on board.
I think for me, some of the key take-home messages from this conversation is the fact that although constitutional causes for delayed puberty makes up about half the cases, that actually it's still really important that we send those to you. I would be following the guidelines and doing it anyway, but it's just helpful to know why that is and that it's actually quite hard to separate those from the central causes. those blood tests, so knowing exactly which blood tests you would find helpful and why, and the thoroughness of the examination, so remembering to look at the skin, doing an abdominal examination, looking for abdominal and pelvic masses, a neurological exam, and the fundoscopy where relevant as well. So just really thinking about how important that thorough examination is.
Yeah.
Thank you. And are there any good resources, either for primary care clinicians or children, young people and their families?
For primary care clinicians, there's a very good article in Archives of Disease and Childhood, a 15-minute consultation on pubertal assessment. It's really, really good, really easy to read, and it's got a few common clinical cases at the end. That's where I point a lot of our junior paediatricians. For parents, the NHS has a really good page on early puberty and delayed puberty and what to expect. And then if you're looking at things like pubertal gynecomastia in boys, so enlargement of breast during pubertal development in boys, and premature adrenarche, there's really good patient-written information leaflets on BSPED, which is the British Society of Paediatric Endocrinology and Diabetes. They're quite helpful. Those are the main ones that I use.
Thank you very much.
Thank you.
Please do give feedback and join us next month for an episode on autism. The contents of these podcasts are for educational purposes, aimed at primary care healthcare professionals only. They do not substitute professional medical advice or consultations with healthcare professionals. Information presented is the opinion of the healthcare professional interviewed, based on their interpretation of best practice and guidelines at the time of the interview. It is the listener's responsibility to compare information given with up-to-date national and local guidelines. The BNSSG Training Hub, Ruth Bowen and interviewees are not liable for any clinical decisions made as a result of this podcast.